All right. So this is going to be a quick update on the Ebola situation. Joining me is the Director of the Pandemic and Emergency Readiness Lab, Dr. Joanne Liu. And Joanne was the previous international president of MSF and was leading the organization during the previous outbreaks, during the previous Ebola outbreaks in 2014, 2016, as well as 2018, 2019. The current picture, and we'll ask Joanne a number of questions today, is that the WHO declared the Ebola outbreak in DRC and Uganda a public health emergency of international concern. There's a number of suspected cases and confirmed cases, as well as suspected deaths, and we're seeing the trajectory of the outbreak increasing exponentially. And unlike the Ebola Zaire strains, there are currently no approved Bundibugyo virus-specific therapeutics or vaccines. And so this is an evolving situation with a lot of domestic and international questions. And so, Joanne, let's just get started right away. What is most worrisome about this epidemic? What makes you most concerned about what's currently happening?
Thank you for having me. So I think what's concerning me the most is when I think of what happened in 2014, 2016 in West Africa, um, in Sierra Leone, Liberia, and Guinea, is there a lot of similar things of what is happening right now in DRC. And what are those things? Say, first of all, is the epicenter of the outbreak is in one of the province called the Ituri province, and it's in the village called Mongwalu. And Mongwalu is a mining city. And what happened with people working in mines is they are mobile people. They move around, they do commercial activities. And so if we talk about a moving person, we talk about a moving virus. That's one thing. The other thing is, as well as in West Africa, it's happening at the intersection of three countries: Democratic Republic of Congo, Uganda, and South Sudan. In addition to that, we have already cases that is spread in popularly densely city, like the capital of the province, and then we even have cases now in Kinshasa and some in the capital of Uganda, in Kampala. But I think the most worrisome things, because this is what we learned from 2014, 2016, is the fact that the chains of transmission are not connected together. So most of the time, what you have is you have one index case, or what we call zero patient, the patient zero, and then everybody is linked together. But we're not able to find that patient that is linking all the chains of transmission. So what does it mean? It means that the virus has been circulating for a while. And so there might be much more cases than what we expect. So we declare a public health emergency concern 6 days ago. We already at more than 600 cases, and we have more than 140 deaths. So it's quite massive. And most likely, I think we're going to have accelerated number of cases for the next while, because we're just starting to contact trace people.
Thanks, Joanne. And you mentioned that there's also the conflict that's making all of this all the more complicated.
Well, the conflict is like the extra variable that we don't have in Western Africa, but we did have it in the outbreak in DRC in 2018, 2019. And it's the fact that actually we have armed groups in this area, in Ituri, but as well North Kivu, South Kivu, and they are really destabilizing the province. It creates insecurity, violence, peak of violence, and then we have population who are displaced. So we can count close to 1 million people being displaced within the province on a chronic basis, and tens of thousands of them very recently.
Yeah, okay. My next question is, I think just for perhaps the general public that may be watching this, can you tell us a little bit about the Ebola virus, what it is, what the symptoms are like, and what makes this particular strain different from what we've seen in the past?
So basically, the Ebola disease has three viruses. So the first one is Zaire virus, Sudan virus, and Bundibugyo virus. The Bundibugyo virus is the one that's been identified in 1994. Since then, we had two outbreaks of it. We had one in 2007 where there was 149 cases. 37 of them died, and we had another one in 2012, 57 people infected, 29 of those patients died. So it's overall 206 patients. So it's not that many patients, and this is probably the reason why we don't have specific tools for it. We don't have enough of a cohort of patients to test medicine or to trial a vaccine. But what we know in terms of incubation is the same thing as the other virus of Ebola, which is between 2 to 21 days. The symptoms are actually very non-specific initially. It's really like a really, really bad flu. So we have back muscle pain. We have as well sore throat, and you just don't feel right. And then you add the gastroenteritis symptoms. Then you have your kidney and your and then you have the kidneys and the liver affected, and then you may go into what we call the hemorrhagic phase.
Mhm. Again, for the general public who is not near that region, seeing all of the headlines that we're seeing with hantavirus and now Ebola, there's been a lot of misinformation around this as well. And I've heard you so many times doing the media this past week saying that Ebola does not have the potential to be the next global pandemic. Can you elaborate a little bit more on that front so that we can kind of put a lot of those panicky headlines at bay?
So basically, why do we think that the Ebola virus is a huge concern for people locally,
Yes.
and very low concern for people remotely in other countries that is not in this area? And the reason is because of the mode of transmission. So to get infected with the Ebola virus, you need to be in direct contact with the body fluids of someone who's infected, alive or dead. So we're talking about blood, we're talking about body fluids like saliva or feces, we're talking about semen, so direct contact. If you don't have this direct contact, very unlikely. Whereas if you have a virus that is transmitted in a respiratory way, like we had with COVID-19 or like we had with the flu, then it's if you are in a confined place, then you can get easily, I would say, infected. So because of that, for people in the area right now, they are more at risk because they have direct contact with possibly people. And one of the risks, it's actually the funerals, because there's a specific ritual in DRC, which is that when someone died, there's some ritual where you wash the body of the deceased person, and as well you touch them, and we want to respect that as much as possible, but it's not possible to do that during an Ebola outbreak, when especially if the person have died from the virus. And so because if we allow that, then people will get infected. One of the biggest vector of spreading the virus more are those funeral ritual. So we need to implement and enact what we call safe and dignifying funerals.
Yeah, so I guess that goes back to one of the questions, you talked about how we do not have therapeutics and vaccines for this specific strain. And so what is in our toolbox with respect to responding to this current situation?
So this is why as well it resembled 2014, 2016, because back then as well, we didn't have any specific treatment or specific vaccine, and then rapid diagnostic tests. And then we go back to the basic of an infected person being isolated and treated, the contact tracing of all the contact of this person, making sure, as I said, of having dignified and safe funerals. But the key thing that we learned the hard way is the information, education, and communication to the general public. And it's really important that we get what I call the community engagement, because they are the one who will make things change. If they are on board, they will do the right thing. They will come forward when they are infected. They will respect the self-quarantine when you've been a contact of a person who's infected. that's what's going to make the difference. And the earlier we're going to be able to get the community on board, the faster we're going to have an upper hand on this outbreak.
It's public health 101, absolutely. I guess one of my last questions, or yes, one of my last questions would be, we're based, the Pandemic and Emergency Readiness Lab is based here in Montreal, and just yesterday we heard about a flight that was diverted from Europe to the United States, and it was diverted to land in Montreal here. Can you talk to us a little bit about some of these enhanced measures that have been taken by some countries, given the very low likelihood of transmission, as you've explained, for folks who are not within that region?
So basically, there is this sort of counterintuitive reflex of saying, if I close my border, I will be safe. And that's a way of thinking, but possibly not the right way. And the WHO, the World Health Organization, always the basic guidance is do not close your border, and then but make sure that you enhance the triage and the screening of people who are leaving the country from places where there are cases. And so there needs to be an enhanced measure for people who are leaving the countries, what we call the exit screening, of making sure that everybody who goes on the flight is being screened for fever, had questionnaire, and then if they've been a contact of someone with a disease, they need to self-quarantine. And by closing border, what we've learned in the past is basically people avoid the official places for border. They move around by foot to another country, and then they travel anyway. And it's more detrimental than anything else. So that's one thing. But one of the key message I want people to live with, if we really want to not have any case here to a certain extent, the best way is to make sure that we are getting control over this outbreak right now in the Ituri province in the DRC, Democratic Republic of Congo, as soon as possible. Because the fastest we're going to get the upper hand about it, the less transmission there will be, the less people who are going to be affected, the less mutation possibly that can happen to this virus, and then it will stop earlier than later.
How do you see, because this is a constantly evolving situation, how do you see this play out from what you've seen in the previous outbreaks to this one over the next couple of months or longer?
Well, if we were to look at what happened in the outbreak in 2018, 2019, there were 3,470 cases, 2,287 people who died, and it took 2 years to get over it. So it's not surprising because of all the same factors of a moving population, but as well of the fact that this is a place of insecurity. So I think right now it's too early to find out how long it's going to be, but we're talking about months for sure. And then as soon as we're going to get the identification of patient zero, and we're going to be able to put together all the chains of transmission, and so therefore we have a much better epidemiologic picture of what's going on, I think it's going to be much easier to project ourselves in the future. Too early.
Perfect. Thanks, Joanne. And I guess last question. A lot of the things that we've heard from students, from colleagues, from friends here is what can we do? And so what would you say are steps that we can do right here in Canada or in the United States to support response or to support the communities that are being affected?
Well, the best way to support is to find out what kind of needs they have in situ in DRC and possibly in the neighboring country like Uganda or South Sudan. And so we already have testimony that apparently they are short already on resources like protective equipment, personal protective equipment, but as well on testing. So maybe they might need increase lab capacity to make the diagnosis. They might need some support in running clinical trials, because I'm sure we're going to try to give a try on testing some vaccines candidates or on testing treatment. As well, we should make sure that that us as Canadian people, at the very least, because the US has decided that the American missionary who was sick did not got repatriated in the state, but got sent to Germany. But I do hope if we have Canadian that we have a protocol that we will medevac someone back home, and then we're going to have designated hospital to care for those people. So we need to make sure that we have medical evacuation capacity with a plane. We need to have identified center or a safe place to take care of those patients.
Thank you. And my actual last question now is, where we heard about headlines on hantavirus recently and now Ebola. And so as, climate change allows us to be even closer and closer to various different types of viruses, I'm assuming that we're going to start seeing more and more outbreaks become more frequent. And so do you have any larger thoughts with regards to needing to invest in preparedness and prevention rather than constantly, panicking and reacting after the fact?
Well, I think that we need to somehow nourish a sort of what I call a holistic approach to pandemic. And this is something that we have a lot of difficulty because there's such a PTSD, a post-traumatic stress syndrome from COVID-19 that everybody thinks that if we don't talk about it, it might not happen. But the reality, it's not the way it works. And I think it's key that we get ourselves, I would say, brace for more. And this is why it's so crucial to get the pandemic treaty finalized. Right now, it is the week of the World Health Assembly. We're still debating the Annex 12, which is about the pathogen access and benefit sharing, meaning that if I'm a country where I have people with a disease like Ebola, if I share a sample of that virus or if I share the genomic sequences, will you give me access to the countermeasure that will be developed, being a vaccine, a treatment, or a rapid diagnostic test? And so far, we're not able to agree. The wealthy country are saying no, and the less wealthy country are saying, then if we don't do that, we might not share with you. So it's really important that we come to a close and we finish the pandemic treaty. For me, it's one of the tools to better prepare and prevent outbreaks. The other thing is as well, and we saw it with the antivirus sequence recently, is the way we interact with nature, and it's the One Health approach. The more we're going to put pressure on the environment, the more we're going to, I would say, what can I say, we go further than the usual, I would say, barrier to nature, then something might happen because we're going to be exposed to new viruses or less known viruses, like it did happen with the antivirus in the Andes antivirus in Argentina. So we need to be aware there's an ecosystem. We need to respect that ecosystem. And if we brutalize that ecosystem, then we might be exposed to viruses that we don't know or know less.
So I hear One Health, global cooperation, some more skills and toolkits needed in our toolbox to be better prepared. Thank you, Joanne, and thank you everybody for tuning in. We'll be back for another update on this evolving situation with Ebola next week. But for now, thanks for joining us at the Pandemic and Emergency Readiness Lab.